And welcome back from our last break of the day. As we move forward into this session, we're talking about how economic evidence has emerged as a central lever for advancing shared understanding and policy development across clinical, policy, and patient communities. Drawing on findings from Precision in Practice, CRAN's National Cost and Benefit Analysis developed in partnership with Signal49 Research. This session will explore how economic evidence can clarify the value of CGP from multiple vantage points and support a more coordinated national dialogue. Panelists in this session, Scaling What Matters, Building on Economic Evidence to Help Inform Policy, will discuss how economic insights can be translated into strategic, scalable approaches to inform future system planning. This panel discussion will be moderated by Dr. Étienne Richer, who is the Director of Genomics Programs at Genome Canada. Participating in the panel, we welcome Steve Slack, a stage 4 colon cancer survivor who will be representing the patient perspective. Eddie Nason, Director of Health at Signal49 Research. Matthew Broham, Senior Global Consultant at Certara Evidence and Access and a member of our Expert Steering Committee. Dr. Stephen Nareau, Senior Scientist at Women's College Hospital Research Institute, and Dr. Sandeep Sadev, Medical Oncologist at the Ottawa Hospital Cancer Centre. Welcome to all of our panelists. A reminder to our viewers to please continue to engage by putting your questions and comments into the question bar below the live stream. And with that, I will hand it over to you, Dr. Richer.
Thank you very much. It's a pleasure to be here today, and it's been already a very interesting conference. So congratulations to all of you that put that together. In this panel, we will indeed look a little bit closer at the health economic aspects with three main objectives that will guide our discussion. The first one being to examine key findings from CGP cost and benefit analysis and their implication for future decision making. The second one being to engage multi-stakeholder perspective on what is needed to support national alignment in the adoption and integration of CGP. And finally, the third objective, to demonstrate how collaborative models can strengthen system readiness for the implementation of CGP across clinical, policy, and operational domains. So again, over the past few presentations and sessions, we've already had some very interesting glimpse of information about health economic aspects of the implementation of CGP in healthcare system and what this can bring in terms of benefits. So great work already that is ongoing, that is being discussed by CRAN and Signal49. So with that, I will invite Steve, based on everything that we've heard so far and your own reflections, if you could just, from the patient perspective, really allow us to ground the upcoming discussions into your experience and to reflect on the impact of CGP and why you believe it is highly important to patients and caregivers. Over to you, Steve.
Thank you very much. Yeah, I guess I'll start by just sharing my story and my experience kind of going through the system and getting the kind of testing that you need to undergo as a metastatic patient. So it goes back 5 years to June of 2021, actually 5 years ago yesterday, where from a colonoscopy I was diagnosed with having a large cancerous tumor in the sigmoid section of my colon. And scans that happened in the days after that revealed that the cancer had spread to my liver, where I had 23 inoperable, unresectable lesions on my liver. I actually needed surgery on the colon right away because I was completely blocked. So I wasn't even able to start treatment right away. The first thing was to actually do a colon resection where the tumor and altogether about 1 foot of my colon was removed. Then a few weeks for recovery for that. And then it was probably last week of August, right before Labor Day, when I actually had my first round of chemotherapy, of systemic therapy. And I guess looking back, for me, the one thing that I remember, and as a new patient going through it, I don't know anything about CGP or biomarkers or anything like that. I have no idea what's happening behind the scenes or what I should expect. But what you learn later is obviously some testing was happening. But by the time the results came in for me, I was already heading into round 3 or maybe even round 4. It was the fall. And I did have, so I ended up being, from a biomarkers perspective, I ended up being a RAS wild type. So that indicated a benefit to adding an anti-EGFR therapy into my treatment regimen. So in my case, it was panitumumab. Anyways, I ended up having a fantastic response with the chemotherapy and the pani. But looking back, uh, I didn't get to start that secondary treatment that was indicated by the biomarker testing until around 3 or 4. So in other words, I really started out my treatment with a suboptimal treatment regimen. So I wasn't doing the absolute best treatment for me right from the beginning, right from, round 1 of treatment, because the results hadn't come back yet. And so for me, there's a lot to talk about in this space with respect to, CGP, biomarker testing, all that kind of stuff, as far as access and, equitable access, but also timely access and getting results on a timely basis so that an oncologist can start treatment, right off the bat with the best possible treatment for the particular patient. So anyway, that's just something that, I've sort of come to ponder over these years that I've been in and out of treatment.
Okay, thank you very much for sharing that. And now, Eddie, would you mind providing a brief overview of the key findings from the CGP cost and benefit analysis that we've we've had phenomena that describing some of it, but from your perspective, and just to help us frame and anchor the discussions that we're going to be having in this session.
Yeah, no, certainly. Firstly, thank you, Steve. I mean, it's great to hear. Firstly, that you're a 5-year anniversary, so congratulations. And secondly, that you've seen the benefit in real person time, and that was the driver, right? This is why this work was done in the first place. There was a clear understanding that there was a need to be able to have some kind of knowledge, the costs and benefits associated with CGP, what it would look like if we were able to get access to it, and so. This study has been talked about a number of times. I've talked about it already during this conference. But in short, the idea was to look at 5 tumors, 5 cancer types, stage 4 metastatic de novo diagnosis, and to work out what it would look like, what would the costs be, what would the sorts of benefits be if you were able to publicly fund everybody who was getting that diagnosis for those 5 cancers to get CGP as their first port of call. And so we basically built a model that allowed us to compare what are we doing right now, where about half the people get CGP and about half get sequential testing, with what would happen if everybody got CGP. Without going into all the details of the modeling, what we found was that, contrary to perhaps where we thought we might be, all 5 cancers for 3 out of the 4 tests that we looked at cost less to the system to do CGP from the start than trying to do CGP, a combination of CGP and sequential testing. And that's predominantly driven by the fact that every time you delay treatment, you increase costs to the system. And so what we saw this actual reduction in cost. That was the cost side. We also wanted to try and work out, okay, well, what's the benefit associated with this? And so we looked at an understanding of where is there evidence that CGP provides economic benefit to people in terms of increased survivability and any other spillover economic benefits. And we wanted to be able to do that in a way that allowed us to compare the idea of CGP versus sequential testing. So we had something to say it wasn't just that the CGP was doing something, it's what would it look like if we were doing the current sequential testing. The only real solid data for that was in lung cancer. But there were parts of that data, whether it was the CGP side or the sequential side, in the other 4 cancers that we looked at, which was looking at lung, colorectal, breast, prostate, and pancreatic cancers. And they suggested that perhaps this was a good starting point as a proxy for us. And so we used that data to model out with an entire understanding of what's the population in Canada who are getting these de novo diagnosis over the next 5 years, 2025 to 2030, and what would it look like in terms of the benefit that we see compared to if we just continued our status quo. And what we saw with that modeling out was over 3,400 life years saved over those 5 years. So that's a significant benefit. We also then monetized that in terms of societal benefit. So using some of the models that we have at Signal49 Research, which is a lot of background economic researchers here, looking at the societal benefit of surviving longer, not necessarily going back into the workforce, but being able to do different things. And so that actually looked at $180 million in societal value that you were bringing back by saving those life years. And so with testing being such a small proportion of the cost of treatment, about 0.6 to 4%, essentially, we came down with the idea that, okay, well, this looks like it costs less, gives us better benefits. What are the factors you might want to include in how you think about moving that forwards? And what are the, how do you create the systems that allow you to realize that kind of benefit? So getting to everybody having CGP and it being effectively used and in the right timescales requires a number of different levers to be pulled. So we also tried to explore some of those and dealing with some of the fragmentation and misalignment that currently exists in the system. So how do we more effectively get testing done in-house, for example, where it's relevant? How would you move things through and provide people with the tools and the training to be able to use the tests in the appropriate ways? So those are some of the things we also brought to light as well. So that was really where the aim of this work was. Thanks, Étienne.
Right. No, thanks to you. And I think this is phenomenal that you were able to bring the societal aspects as well, and not only the direct costs, but also demonstrating that just in terms of direct costs, that there was a cost savings there that could be realized, could convince the decision maker at some point, hopefully. So no, that's great. So we're going to tackle now the first objectives, which is again, like really thinking about the key findings from the CGP cost and benefit analysis that we've just heard about. What stands out to you and what implication do they have for the future decision making related to CGP in Canada? And maybe Matthew, if you want to elaborate a little bit on that. Oh, you're muted, Matthew. Someone has to do it every time.
Thank you, Étienne. Yeah, my apologies. So on the face of it, what we have here is a very compelling economic case. So we see cost savings from a resource use point of view, and we see life year gains. And we also see some estimates of wider societal benefit. So the question becomes given that, and given that we've heard this a few times over the last few days and previously, why is the technology not utilized extensively and not funded everywhere? Well, I think it reflects three possibilities. And interestingly, they've all been discussed over the last 2 days. I think you can boil it down to, or you can look at it from three perspectives: poor decision-making systems, uncertainty about whether or not this economic analysis is up to scratch and thus, sort of meets the decision-making criteria in these systems to offer a yes to funding. And thirdly, what frequently isn't considered in these analyses is the insurmountable transition costs that are involved in moving from current state to a future state. And I just want to briefly talk about those three issues. So there appears that there are some good systems in place in Canada and perhaps some not so good systems. What do I mean by a good system? Well, I think a good system has explicit criteria and sound processes, and you get regular assessment and decisions out of those systems. Poor systems tend to be ad hoc and opportunistic. And while they can be nimble, the problem with them typically is there's very limited opportunities for accountability. So systems can get away with not moving these things forward. We heard yesterday about CDA's framework, and I just want to point out that a universal assessment framework for biomarkers is not the same thing as as a decision-making system. This is something that has to happen, has to be something that's in place where the decision makers make the decisions. So what is the opportunity here for advocates in particular? I think it's to push for decision-making systems, for good decision-making systems. And there are plenty of material that basically can outline what those look like, but mainly in terms of process. Process matters more than the criteria frequently. And the reason I think that's a good thing to advocate for is because in the absence of that, we tend to waste our resources. We waste them arguing with each other, and we waste them not making decisions about how to effectively allocate resources. If you look at the second issue, which is one around some degree of uncertainty, Signal49's analysis is very positive. Other analyses have shown some net cost associated with going down the CGP path. I just point out that it's extremely rare for a new technology, for an assessment of a new technology to result in a slam dunk. It frequently doesn't happen. And the reason for this is almost always differences in assumptions. And one of the big things that drives differences in assumptions are risk tolerances. So funders tend to err on the side of minimizing the risk of overspending. And their reason for doing this is because they don't want to limit their opportunities to fund something better, essentially. So they're trying to always fund the things with the lowest opportunity costs. And the patients, of course, err on the side of minimizing immediate loss of life. And sometimes these two things are not the same thing. So those differences will always exist. I should point out that when you do an analysis and you get a net cost, then obviously you have to understand what are the benefits to the technology. And this becomes even more complicated. I think here we have an analysis that shows net savings. If that's to be believed, then it's a no-brainer. It's an allocatively efficient thing to do. But where there are net costs, we have to look at the benefits of different biomarkers. And just to support CDA's position on this, I would suggest to you that a biomarker by biomarker approach to this analysis is actually vital. It's actually, this is a very difficult job to actually assess that evidence for each biomarker. And so whether you do a panel or whether you do it by biomarker, you're still going to have to look at the evidence for each biomarker. So what is the opportunity here? Really, CCRAN has taken one opportunity here to provide the decision-making systems with the analysis, with some additional analysis. That, I suggest, is not always necessary by advocates, but what they can always help with is helping decision makers identify all of the costs and benefits. So finally, transition costs, and I think this is where we basically have a major issue here, and of course it's been a major part of the discussion. And as I said right at the get-go, you have state A, you compare it with state B, and you find state B is better than state A in terms of resource use. And ultimately, in this case, under some assumptions, better in terms of life years gained. But that doesn't tell you how to get from A to B. It doesn't tell you what the costs are involved with A to B. And quite clearly, there are barriers in the system, and there are a bunch of behaviors and habits and routines that need to change. And I have to say, in my experience, in these sorts of decisions that have routines and habits that need changing, we tend to always underestimate the costs involved in making those changes. They're very, very hard to make happen. And clearly, there have been discussions over the last 2 days aimed at trying to understand what those are and advocate for removing them or changing them. And that, again, is really the opportunity. It's essentially for advocates to amplify the existing knowledge translation processes that exist. And, we've got a perfect example today. The last 2 days have been fundamentally about that.
Right. Thank you for that perspective. And clearly the translational science and the change management is something critical. Eddie, do you want to react to?
Matthew is absolutely right. I mean, there is no argument that those three conditions are all things that are factors into why people don't or do make decisions in how they decide to move forwards. And I think the interesting thing here is, as Matthew's pointed out, who has either opportunity or responsibility to do something better. So there are better decision-making opportunities there. So when it comes to things like how do you shift from one state to another, where's the evidence you need to show you what that looks like? I don't think we even have a really good idea about what each of those current states currently looks like or costs. And so one of the things that we're very interested in is being able to say, okay, well, how are people doing it right now? There is this hybrid version of state A and state B occurring in different provinces around Canada, occurring in different ways. How would we understand what that looks like? So we can get to the point of saying, okay, well, if you want to realize benefit, you want to realize cost savings, here's the things you need to do. Here's where you need to move yourself. And so I think Matthew's points are really valid and very important for everybody across. I mean, this is beyond advocacy. This is the research tables. This is the decision-making tables, the administrative side. We all need to understand that this is a part of how we get better at doing what we're doing. So I think these are really excellent points.
No, and I also agree with you, Matthew, that there's clearly a decision-making gap in that the framework from CDA is the level of the recommendation, but that's inherently how our Canadian system here is working, with the provinces and territories making ultimately the decision, and like these clearly identified actors where eventually we need to move, and the person that will need to be brought into the discussions to bring the change in attitude or like change in the system that are required to better serve patients. Okay, is there any other panelists that want to react or to add something at this point? Or if not, we can move to the second objective. That one here. So that one here, objective 2, from your perspective, what is needed to support national alignment in the adoption and integration of CGP across Canada? So again, it goes back to the idea of the decision making. So Matthew, can you reflect on the gap between the evidence and implementation, including the roles of knowledge transfer in supporting the implementation of CGP across Canada?
Okay, well, I think universality or aiming, I mean, this was discussed briefly yesterday in Don and Eddie's presentation. The aim, I mean, I'm a New Zealander. I come from a system that's a small country with universal healthcare across the country. And so when I came to Canada, it just seemed bizarre to me that we had all these different systems in place, essentially redoing each other's work and sometimes coming up with slightly different decisions, although oftentimes coming up with more or less the same decision. But over the years, I have, been Canadianized and, understand the FPT sort of framework that exists here in Canada. And healthcare is a provincial jurisdiction. So I think aiming for universality is really a mistake under Canada's system. And again, that was discussed yesterday. But there's no reason why one cannot borrow from other jurisdictions what's working well and, bring it to the table within one's own jurisdiction, or indeed even look at jurisdictions outside of Canada and what they're doing. So, that would be my first comment. I think having, and this has been a discussion at the HTA table around the world for at least 2 decades, to my knowledge, and possibly even longer, is, what is the role of HTA? Is it a localized kind of research process, or is it more able to be essentially a nationally or pan-Canadian type of process? And we have moved clearly in that direction, and continue to move in that direction. And by that direction, I mean making it a pan-Canadian thing. And the benefits of that are that you don't rework essentially what are very complicated analyses on multiple different desks, and you're able to utilize those results within your own decision-making framework, so long as those assessment systems provide you with information that are in your decision-making frameworks. And again, to CDA's credit, they have, in this instance, biomarkers tried to do exactly that. They have tried to make sure that they are looking at criteria, looking at analysis evidence that is that they can pronounce value on in a way that is useful to the provinces. And again, if you think about that, that's an incredibly difficult exercise to do, given essentially the number of provinces that we have that are doing different things. So that's a less of an economic analysis and more of a policy analysis of how to improve decision-making systems. Basically, they need to be, in my view, provincially brought to fruition. Obviously, they could team up if they want to and create clubs and do things similar in some jurisdictions and different in others. And I always remember, people asking me, well, why does one decision-making body come up with a different answer compared with another decision-making body if you look around the world, when essentially we have the same evidence? And the answer to that question is we have different risk tolerances and different preferences. Each group of us, each jurisdiction, those things are actually quite different. And those things get factored in when you have to make these decisions. So we shouldn't be too surprised if we get some degree of difference in access to these sorts of technologies when you're looking at a country as vastly spread out as Canada.
Thank you. So in terms of the system and again, like looking to the implementation across Canada from a clinical perspective, Stephen, would you mind sharing your perspective on?
You're asking me?
Yes, please.
Yeah, well, I'm no expert on the area of cost benefit, but I certainly have looked at a lot of pan-Canadian programs which are provincially based, the healthcare system being provincially based. And because doing this is in the context of breast cancer, we find that many of the tests that are ordered, for example, breast cancer probably has the longest history of genomic profiling with effective tests, MammaPrint, DX, etc. And the policy varies from province to province. What's available free in Ontario is not free or for the patient in Alberta or the Maritimes, Oncotype DX, for example. These are very interesting tests in the point of view, we talk about cost savings. I haven't really thought about it, but they're usually used, the most prominently used, to make the decision to avoid chemotherapy. I know Steve was talking, we generally talk about colon cancer and pancreatic cancer in the additional chemotherapy given for people with particular mutations. But in breast, it's funny that we can, I guess Sandeep knows about breast, but we can reduce the amount of chemotherapy, what we call de-escalate, without harming the patient's life expectancy. And that, I think, is a huge possible benefit. On the other hand, I sort of think of it, the companies that provide the test, private companies, do so at a pretty high cost. The cost is high enough that some provinces would have chosen not to make the test publicly available. For example, I believe that if the test was $1,000, everyone in Canada would have access to it. But the test is priced at $3,000 to $5,000, which made it a big, the kind of decision Matthew was talking about, who wants to pay it. Those of us in Ontario, I do think, should feel fortunate. We generally get more options in the healthcare system offered to us through OHIP than most of the other provinces, to what I'm aware. Certainly in the breast cancer. I just wrote a book about, it's kind of talking, Steve is talking about his decisions. My colleague Kesha Zeshek and I just finished a book coming out in August called 10 Questions to Ask My Doctor About Breast Cancer, which is really designed for the patient to take home, take a week or so to look at the 10 questions. What should I do about chemotherapy, radiation, tamoxifen? And two things stuck out for me. One is how enormously fast it's changed. The breast cancer world has changed in the last 5 years more than it has in the 30 years before that, with the introduction of lots of these adjuvant chemotherapies, and specifically for ER-positive cancers, and the tests. The genomic testing we think is great, but it sure adds a lot of complexity to the question, almost to the extent where I thought, I tried to write this book to help the patient get through those initial few weeks and wonder if I can do it. The complexity has gotten to the point where sometimes many of the patients will say, I think half the patients will just throw up their hands and say, doctor, you tell me what to do. I can't take this. Half the patients will say, well, I really want to have an information. I want to make an informed decision. And that would have been simpler 5 years ago than it is now. And I have to tell you, I'm not a medical oncologist. I'm a public health epidemiologist, genomics guy. But the level of complexity that's being added by genomic tests has made it extremely difficult for the oncologist, the medical oncologist, and the surgeon, and these people. And I think for the patient, guys like Steve, I have to admire that you want to tackle it and think about it, because I'm not sure everybody does. And I think about this every day.
Thanks for sharing that with us. Anybody else on the ways that are knowledge transfer that would actually support, or knowledge mobilization that would support the implementation? Or we can come back at this near the end also of the session. So in this case, we're going to move to the objective 3, which is how can collaborative models strengthen system readiness for the implementation of CGP across clinical, policy, and operational domains. So I think there's already a lot on that has been brought to the discussions when we were talking about the policies and the evidence required and the risk tolerance as well. But Sandeep, if you want to start elaborating on that one, that would be great.
So can you rephrase that question again?
Yes, how can collaborative models strengthen system readiness? So really, how can we collaborate together and make sure that things are not done in silo, essentially, and that we can really broad the clinical, the policy aspects, decision makers, and but also those that will implement eventually, I guess, with the idea or the hope to better define how to go to that state B, which is better, and get a better idea and reduce the risk or uncertainties, I guess, of the change management or change process.
Yeah, I asked you to repeat it because a lot of the stuff we touched on a bit already. I didn't want to reinvent that, but it's a key question. I was kind of nervous getting ready for today because it's a very broad topic, for a short discussion, and it spins my head all the time. We talked initially about costs. Clinicians don't really care about costs. And my observation has been that going back 35 years now in practice, every technology we do, even though you might at one angle or another show cost savings, it always ends up generating more cost at the end of the day. It may drive us to a new treatment that's going to cost more than the old treatment. People live longer, need more doctor visits, more scans, etc. So the whole idea of cost effectiveness is wonderful if we can show it, but it's not the whole story. The issue of cost effectiveness, and it has to be, again, judged against clinical value. What is the benefit? Our real goal is to make patients better, less suffering, live longer, do better. And we have to kind of show that at the end of the day. And the silos is the key problem. I think this has been touched upon in every discussion, but the siloism in Canada, it just blocks us at every step. I've been around, long enough that the first new technology was a new drug, paclitaxel, back in '91. We invented the new drug funding program in Ontario just for that drug. And now it's used for everything. We wanted to have collaboration. We wanted to avoid disparities amongst hospitals and who gets what where. That kind of set the bar. I think now PET scans in the late 90s and early 2000s were the same thing. Canada went through a ridiculously painful, torturous process to disease by disease prove that PETs were cost effective. Whereas, leaders finally got the common sense that we cannot treat cancer if we don't know where it is. And if we don't know what shadow is cancer or what isn't cancer, so now it's become more broadly available. We wasted more than a decade with BRCA testing that, Stephen was such a leader in. We still don't have it enough. We don't have access enough today for our average patient with breast cancer. We're not following international guidelines on it. So we need to break down the silos and collaborate to help do that effectively. Right now, there is no legitimate reason, I think, why the decision about yes or no to any test or treatment should be any different than any province. We're a relatively small country. The budgets may be different, but it's not a cultural or language thing. This is cancer, a scientific thing, and most Canadians fall into the same biological buckets. So I think we need to work at the political level and collaboration amongst the stakeholders, i.e. the patients, the individual patient disease groups, the large disease groups like Cancertainty, groups like mine, the CCAF I'm a co-chair of, was meant to bring together a broad variety of voices across every cancer type. We have hem-onc, gyne-onc, pharmacists, nurses. If that voice together, 25, 30 signatures say, this technology for breast cancer is a slam dunk, why aren't you doing it? It carries a big punch because it's obvious to people across the spectrum in cancer that this technology should move forward more broadly. So I think what we can do is collaborate our voices together to agree upon a common framework and how things should be done. The other key message for collaboration is, I think what Stephen was talking about, is a pan-Canadian process. It has helped us. There are efforts now to even go international, to share with other countries jurisdictional issues, but share decision-making about regulatory approval, to cut waste, to divide and conquer the workload, special access programs to collaborate with European countries. We have to collaborate to keep up. Stephen made the point about the advancements in the last 5 years. I used to treat every kind of cancer in Toronto. You can't do that anymore. I just do breast and melanoma now. And the deluge of things, all genomically driven, is huge. We need to collaborate also with voices amongst the research communities. The Canadian Cancer Society is a powerful, respected advocacy voice, very objective, beyond any influence. And their whole theme this year is clinical trials and research. We have trouble getting patients on clinical trials because to stratify them and qualify them, you have to have the biomarker. And we can't get the biomarker to even see what's going on. Having spoken with ministers of health in the last 1 year and leaders of cancer agencies across the country, I sense that the cost argument alone won't do it. The cost effectiveness won't do it because the silo for the drug budget is different. No one seems to care about the cost of the whole system. It's my drug budget, it's my hospital budget. These tests are often done, if we do them locally for $700, $800, it's the hospital decision. Some hospital labs are kind of private consortium labs that do them, and they won't take a $100 loss if the government pays $700 for $800 test, whereas sick kids will and other hospitals will. And that needs to be standardized. So I think our coordinator, our secretary at 360 Public Affairs, has made the point that we need to do things that help us integrate vertical and horizontal integration across the country on key themes. I didn't hear the presentation by CDA, but they have a process for new drugs. They should have an identical process for new tests. And they should have lead experts say, this test today is ready for prime time. It should be implemented right away. The provinces that take part in the pan-provincial process should be almost compelled to buy into it. And every hospital should be kind of allowed and budgeted to implement it broadly, equitably. In Toronto now, William Ozer, where I used to work, has a very powerful molecular pathology leader. They'll get almost any test you want through their own local budget if it's reasonable. and 2-day turnaround time, whereas PMH can't get some of those tests done. And there's no logic in Quebec and Montreal. I've heard this disparities, hospitals down the street from each other on what will be offered, what won't be offered. And that's not acceptable to Canadians. So I think just having those broad themes that we should do it the same way, our patients deserve it, the outcome is clinical benefit, survival, eligibility for research studies. We're not getting, our numbers of studies coming to Canada has dropped 35% in the last few years. We're becoming like a second or third wave country because we've had such fragmentation of our clinical trial legal negotiation or contract negotiations, hospital by hospital. So we need to really coordinate things together. And I think if all of us together add our logos and our voices together, to op-eds or to statements to ministers saying, look, this is the problem. We have to get these silos fixed. Let's move forward. We can't do it the way we used to. It just takes too damn long.
Yeah, thanks for that perspectives. And yeah, I totally agree also with the fact that like supporting objective evidence generation is key, and having organizations like CRAN working with Signal49 and building that evidence clearly is a huge step. So going from pure advocacy to supporting and generating and being a member, full member of the ecosystem, working toward that solution together with others. So clearly that talks about the intersectionality that question or that objective was bringing to the table. So thanks for bringing that. And speaking of which, Eddie, do you want to add a little bit talking about evidence?
Yeah, two things that jump out at me from that, and Étienne, you'll be bored of hearing me talk about impact, but impact doesn't occur in the world unless lots of people from lots of different factors work together. Like you work impact through multiple systems, and collaboration is so important, both in terms of the things that happen within systems, so whether that's defined by the types of clinicians and the lab workers that might need to understand each other better, but also across systems. The other thing I want to really jump on, which is Sandeep's point about the drug budgets being different than other budgets and the fact you don't see savings, you see movement of money. This issue is what we've called harvestable savings, is that we can show you that this might be beneficial to everybody, but unless that beneficial component is also beneficial to the cost you originally put in the drug budget, for example, it's very hard to convince people to say, okay, I'm willing to spend more to save more elsewhere, because we've developed systems that are aligned in horizontal approaches. And that's really, really challenging to get at without having some form of collaboration that lets you say, okay, well, actually, maybe there are ways to move things around between us. How do we collaborate to make sure we're all focused on this end goal, and we can therefore work out where our different roles are in delivering on that and the value we each bring to it. So I think there's a really core component. So Sandeep, I very much appreciate you bringing that up.
No, indeed, that's a key point, and clearly something that generally speaking, when we're talking about precision health, personalized medicine approaches, that is a hot topic of discussions, because we cannot use the traditional HTA approaches using like one drug versus the other, which is within the same budget, as opposed to having impacting the overall health of the population and improving that at various levels. So finding ways to move the funds between those silos and having a more of a systemic approach level can certainly be a driver here. Anybody else? Now that we've done with
Can I
these.
make a quick comment?
Yeah, please.
Yeah, just going back to the BRCA1 thing and BRCA2 gave me a moral dilemma. So the genetic testing is different in every province. They have a qualification through the government, paid through the healthcare plans. Generally, you go to the genetic council, they evaluate you, get a genetic test, and that would be covered by the provincial healthcare plan. 8 years ago, I set up a private project myself, me and another guy at Women's College Hospital. We offer genetic testing to anybody in Canada. No requirements, no family history, no personal history. It's available to anybody who wants it without any doctor referral. And it costs $500. Like I made sort of a personal decision, confronted by this. Do I try and bring everybody together and lobby the government of each province to offer genetic testing to more people? Because people were being denied genetic testing, and they were said, well, you can't have it, therefore there's no opportunity. And they said, well, what if I want to pay for it? And they said, well, there's no opportunity. So I gave them the opportunity to pay for it. We do about 1,000 tests a year now, and people seem to be happy. I mean, I know it goes against the Canadian healthcare philosophy, but given the fact that it's not covered, it's also illegal. So, I just sort of wondered about that. At the $500 level, is that prohibitive? Is that something we shouldn't be doing because not everybody can afford it? Or should we just say, look, if the government doesn't offer it for free, you have the opportunity to purchase it? This is a real, I mean, we've had a lot of discussion about the morality behind it, but most people now think it's a good idea.
And using approaches like that, if you can also collect data and information and generate evidence along the way, that can certainly be very interesting. Okay, so Steve, would hand it back to you if you can bring us a few reflections from you started that panel. Sure. And now that we've had a chance to discuss the various objectives.
Yeah, a lot of things. It was a great discussion. I was following along, and I think putting on my patient hat and speaking on behalf of patients across Canada, I think the first emotion I feel is quite honestly frustration, and I want to clarify, not with the panelists. Panelists are wonderful, but the issues that you kind of pulled out through the discussion. I'm listening as a patient and hearing about this, and I have patients that I'm connected with in just about every province in this country. And I'm hearing about decision makers and bad decision makers and decision makers that don't believe necessarily the data on which they would base a decision. All these silos, all these individual jurisdictions, because healthcare is provincial. And, on one hand, I can think that, I understand that in some situations with healthcare, a decision that's best for an Ontario system might not be the best decision for a Prince Edward Island system or whatever. But I think what I'm gathering from this is that there's so much needs to be some sort of coming together nationally, something comprehensive when it comes to these kinds of decisions, because at the end of the day, it's not fair. Like, I think I speak for all cancer patients in the country when I say we feel like it shouldn't matter where in the country we live. We're all Canadians. And so because I live here versus there, shouldn't matter whether I have access to a test or whether I have to pay for a test versus having it covered by my provincial system. I think it's quite frustrating. And I'll just sort of go back to the beginning in terms of my own story, just to elaborate a little bit more. So I had some biomarker testing done on me when I was first diagnosed, but I never had CGP. And so it leaves you wondering, like, what if some sort of, something had been found had I done CGP and there was some promising targeted mutation or something that we could have done something with, that could have, I mean, overall, I've had a good outcome. I'm 5 years survival and I'm no evidence of disease at this point. But I mean, what I had to go through to get to this, I had to have a living donor liver transplant. I had to undergo like 34 rounds of chemotherapy. I had to have a hepatic artery infusion pump done at Sunnybrook in Toronto. I've been through a lot. I've been through the gamut. And I just wonder, could I have had an easier path if I had had access to CGP 5 years ago when this all started for me?
Thank you. And I think that this actually echoes and answer one of the questions that we received from the audience, which was directed to you actually. So from the patient perspectives, what are your thoughts on poor decision-making systems limiting equitable patient access to comprehensive testing across our country? So
I feel like I crushed that, hopefully, because I expressed some very strong feelings about that.
Feelings that are clearly that are understandable, and that we need collectively with all patients, like all stakeholders, like going and working through that together, and making sure also that politicians and members of parliaments and like both at the federal and provincial levels can actually hear those messages that are very important, again with supporting like strong evidence that is being generated. So there's another question here for the audience. So cancer drugs are very expensive. What position against how much treatment costs? When positioned against how much treatment cost, what proportion of this goes to the cost of comprehensive testing? So Eddie, I think you've mentioned a little bit like the small, or someone else on the panel, the small cost of testing versus drugs.
Yeah, so I mean, when we did the analysis we used was based on how people were treating those tumors at this particular time in 2025, and the cost of the test was anywhere between 0.6 and 4.1% of the total cost. Almost all of that cost was driven by the treatment cost, and with some of those new drugs that may be very effective but very personalized, those costs may get even higher. And that is a realistic concern. And that is one of the things that Matthew's saying, I think, is about there's a risk associated with how do we do something that really effectively delivers on what we want it to without creating additional risk for us in the system as a whole. And so understanding what you're doing right now and understanding what implications it might have is really important to building an equitable and an effective system.
Great, thank you. So we do have another question here. Are the panelists supportive of coming together and moving towards CGP becoming a standard of care? If not, why? So any panelists, pros or cons, or someone that would be not supportive of moving forward?
Well, I won't say I'm not supportive, but the issue is quite strongly highlighted by, well, it has been highlighted by Eddie, it's been highlighted by Don, and it's been highlighted in the discussions here as well. You know, it's not a slam dunk. Potentially, it's not a slam dunk. So at the end of the day, you have to get over that hurdle. Is the uncertainty so high that you can't move? This wouldn't be a good way to move forward, or is it actually a reasonable bet? And personally, I think it's a reasonable bet from what I've seen, and I'm sure others on the panel agree. But you can always envisage making quite significant mistakes in terms of resource allocation in these areas that just simply raise costs and produce no extra benefit.
Well,
and that is a worry for decision makers.
It depends a lot
So
on
maybe
the test,
Steve
right?
and
So,
or Sandy, yeah.
yeah, I mean, if you have a CGP panel, like in lung, you have to do a panel because there are many potential new targetable, markers. In other diseases, there may just be a few, but the CGP test is actually as cheap or cheaper than doing a bunch of separate tests separately and using up your pathology. But if you find something on a CGP, which may not be a driver mutation, for which we don't have any proof of efficacy of drugs, many studies have found that just going after that as a late line of therapy almost never has benefit, and it can lead to false hopes and unnecessary toxicity, poor quality of life sometimes. So it has to be looked at with a grain of salt. It's not a panacea, but they do identify people for clinical trials, especially when you don't have good treatments or you run out of good treatments. You identify people for clinical trials for new drug discovery, which is very important. I think most clinicians want the testing done when we have a treatment for it. And there are many tests in Canada where the test is only funded if the treatment is both proven and funded. And we don't want that. We want a test where there's proof of treatment efficacy, funded or not. So then we can push for funding for the drug, or we can refer a patient to another jurisdiction or a country where it's available. At least they have the option. But Canada right now, we have this other crazy lag from evidence. It takes 2 years to get funding. And we still need to have access to the testing to at least inform the patient. So I think it's a bit of a multi-layered answer.
Thanks. We'll come to you right after, Eddie, but Stephen, you also
yeah, I just want to say, I think we're all, as a researcher more than a clinician, I mean, everybody would agree that research in this area has been very promising, that the majority of what we consider precision oncology, personalized medicine for cancer, comes from the idea that we can look for driver mutations within a cancer, and these are druggable, and there's drugs which will be the target. That has been successful, and we all believe, I think they're unanimous, that that's a really valid way of spending our research dollars. The question is, of course, at what point do we take the findings and turn them into clinical evidence and fund the drugs? So I mean, I'm skeptical in those kind of terms. Like my job is to be kind of skeptical about looking at laboratory results and clinical studies and say, well, what are the shortcomings of the study? But even as a skeptic among the group, I think this has got to be the way forward towards where we want to be. The other way forward, we got to find guys like Steve getting colon cancer in their 40s that are metastatic. I mean, there's got to be, we have to think about early phase. We've got to think about screening. We've got to think about genetic predisposition. We've got to think about better screening and cancer interception. Because, waiting until the person has metastatic cancer, what this panel is about, is a challenge. It's part of a big spectrum of challenges.
Thanks. Eddie.
Yeah, I'm going to build on something that Don and I talked about yesterday, which is that I think in general, as Matthew said, there's probably, if you were to make a bet, this is a good thing to make a bet on. A, because there's a significant amount of evidence that seems to be pointing this direction. And B, because as you know, Étienne, this is moving fast. Like we will have significantly more benefit from CGP type genomic testing in 3 to 5 years time than we have right now. So I think there's a lot of opportunity that we need to set ourselves up for. I think the key here is that understanding that you can have this as an opportunity to use, but the implementation of it looks different in different locations. So the way a PEI sets up its system to use that evidence might look different to the way an Ontario sets its system up to use that evidence. There are contexts, there's risk issues, there's policy issues, there's health system structure issues. So we're not trying to say there is one size that fits everything across Canada. We're trying to say this is an approach we think you should do. Let's work out the best way to make this work where we think you in a context that works for you. I think that's what we mean by universal.
Great, thanks. And there's a comment from the audience also mentioning that it would be unthinkable not to incorporate CT in a patient's workup. At one point, it was quite expensive, and now it's being considered as potentially not worthy of inclusion in budget, as like a demonstration of comments showing that things like uncertainty shrink with time, and that decisions today are quite obvious when it was not the case. Actually, I think going back to Matthew's comment, when uncertainty was higher. Yes, Eddie.
Yeah, just on that, I mean, in the study that we did, if you go and look at the results and the findings, there was one of the 3 tests that was not reducing costs because it was more expensive. Within 2 months of us releasing that report, the cost had gone down. If we ran it again, that may now be reduced cost rather than increased cost. So this is how fast the system moves. Like, I think this is something where the evidence is obviously shifting on a regular basis. Don's work on system readiness has always been about how do you make sure your system is ready when you do have new evidence. And I think we're trying to suggest that, okay, well, let's work out how we get these things in place so that we can actually use it as we get much better at using this kind of evidence in practice. So.
Yep. Steve, do you want do you have a few last words to wrap up this session?
Me?
You unmuted yourself a little bit earlier, so I thought you might wanted to add something or.
Oh, no, I'm good. Other than I would just say, thanks for inviting me to the panel to have the patient perspective. I do think it's, an important part of the conversation, and maybe I don't have a lot to add from a technical or scientific basis, but hopefully my perspective, definitely sort of helps frame the conversation. And thanks for having me here.
Certainly, and thank you so much for coming and sharing your experience, and congratulations again on your 5th anniversary. And with that, Cassandra, if you.
Thank you so much. Well, that was a great panel, really diverse perspectives, which always drives very thoughtful discussion. So thank you so much to all of our panelists for contributing today. I'd like to just kind of take it back to the patient perspective as the final kind of reflection on this session. And, we heard something powerful from Steve, and that's that there's still so much frustration from the patient community, and access to advanced testing really shouldn't be dependent on geographical location or financial privilege. So Steve, thank you for anchoring that discussion in the patient perspective as well.